Hello everybody, welcome back to the platform of Unacademy, and today we are going to have the second marathon revision of neonatology so that we are going to finish off all the important questions and the practice from neonatology. So yesterday we had discussed important questions from Neonatology Part 1, which was basically an example of questions which are very simple one-liners that are asked in the exam. So we always have two types of question coming up in the exam, which includes your one-liners and it also includes your concept-based question. So it is very important that all of us are well versed with both pattern of questions so that you are able to answer any kind of question that comes in the exam. So today we are going to fastly revise all the important 50 set of MCQs that we need to study for our neonatology. So I hope all of you have finished revising your neonatology part. So it is going to be a marathon MCQ revision. So I want all of you, those who are listening to the class, to start typing in your answers in the chat box till we start. So let everybody join in, especially those who had attended yesterday's class. So if you're meeting me still for the first time, hello to all of you. I'm Dr. Kavita Srivastava. I'm MBBS and MD Pediatrics. I also specialize in pediatric pulmonology and management of critically sick newborns. And my achievements include being a 10 CBSE topper, a green scholar of my high school, and MD silver medalist. So for those who have not yet subscribed, we have a lot of good subscriptions running right now for your NEET PG exam and the preparation. So we have a very basic subscription, that is the plus subscription for all of you, which includes all the important parameters that you require to create a complete blueprint for your preparation. So कितना पढ़ना है, कहाँ से पढ़ना है, कौन से topics पढ़ने हैं, everything is going to be covered if you have a plus subscription. So those who have not taken any subscription, I request all of you to please come and subscribe so that you are able to study in a design pattern and you're able to understand everything nicely for your exam. So those who are only following the YouTube channel, I would also request you to come and join the special classes and also take a plus subscription so that you can study all the topics and all the units in a systematic manner. So under plus, you have got access to both live and recorded classes. You get to learn from the top educators. You compete in the tests and quizzes. You can study from the device. You get access to questions and you also get a set of handy notes. Above this, we have got Iconic, which is a combo subscription of Unacademy and Prep Ladder, where you get benefits of both of them and you are able to understand the topic and you can assess yourself from another media to solve the MCQs and see your rank. So last 1 month package is still running. Those who are going to appear in this year's exam, you can still appear for the grand test. So the test dates have been announced. And those who haven't taken any, you can still start to appear in the grand test to assess yourself. And for all of you, we have this NEET PG 2021 final bout, which is tomorrow on 4th September 9 a.m. So once you start to take this, you will be able to assess yourself very nicely because all the educators have put in a lot of effort to prepare you till this level. So we still have the 12+2 offer valid. So if you take this subscription, you will get 2 month free subscription on your whatever package that you're taking. So you can access your course for another 2 months for free of the cost. And we have the 4-year subscription plan in which the plus is going to cost 60,000 and Iconic 75,000, but this is for 4 year. You can prepare for your all the MBBS subjects from foundation basis. And also, good evening to those who are joining in. I'm glad those who had attended yesterday are joining today. So you can prepare for NEET PG and Prof both. So to sum it up, we have Plus and we have Iconic. जब भी कोई subscription लेते हो, please take it for a good duration of time so that you can revise it properly from all the sources that you have studied. So जहाँ से पढ़ते हैं वहीं से revise करना होता है. So please take it for good duration of time. Whenever you take any subscription, please use my code, that is Kavita S10. If you put down this code, you get additional 10% discount above the discount that Unacademy is offering you. Okay, so let's begin with the quiz. Those who are ready for today's quiz again, welcome to all of you. So we are going to firstly discuss these concept-based MCQs. So concept-based MCQs कहने का मतलब है these questions are lengthy. These questions require attention to read the question. They require a lot of patience to understand the question, but the answer is very, very simple. So here you're going to be tested on your behavior towards the exam. आपका ADHD का level क्या है? How fastly you read and how much mistakes you can make. ठीक है? So questions are very simple. It's not very difficult also. Some of them are of another level. But that is important because then only you get a differentiated rank in the exam. Those who have studied a lot more would be able to answer all the questions. Okay, so question number 1. All of those who are listening, again, I request you to please start typing in the answer in the chat box, because once you don't exercise your brain, you won't get into the habit of solving MCQs. Okay. सो यहाँ पे डायग्नोसिस ऑफ एक्सक्लूजन मेथड बहुत अच्छे से यूज होता है. पहले वो आंसर रूल आउट करो जो बिल्कुल भी आंसर हो नहीं सकता, एंड देन अराइव एट द राइट आंसर. ओके, please read the question carefully. Don't jump into answering it. It's a very, very tricky question, but it's very simple to understand. So those who are still reading and thinking, I'm glad that some of you might come up with the right answer. So it's asking you that an infant is diagnosed with some of the given disorders, which is given below in the options. Which of these can have the greatest recurrence risk in the patient's future sibling? So please read all the options carefully. सबसे ज़्यादा recurrence risk किस condition में हो सकता है? That is why I've put this question as question number 1, because I want all of you to be very, very patient with questions. Okay, have a lot of patience. If you have patience and you're calm, you'll be able to read the question properly and understand what the question is demanding from you. Please go through all the 4 options and choose the right answer. Option A, B, C, and D. So for those who have jumped into option number D, I was very sure I would get that answer, but please rethink once. Option number D is not the right answer, obviously. It is asking that out of these, that means out of only these 4, which of them would have the highest risk of recurrence in the future siblings? So in trisomy 21, which is Downs, how much percentage holds for the Robertsonian translocation part, which can have 100% inheritance or a very good inheritance in the future sibling? And out of these, what are the other options that are given to you? Which of them is again a genetic disorder which has got autosomal recessive inheritance, and it has got 1 out of 4 siblings who could be affected in the future pregnancies? So which option would you choose? If you think, ponder a little bit on this question, you will come up with the right answer. So would you like to revise your answer now? Did you understand the meaning of the question, what the question is demanding from you? It is simply asking which genetic disorder has the maximum risk of recurrence in the future pregnancy, and knowingly they have given you Down syndrome, because everybody would think that is the answer, but that is not the answer. Downs is out because Downs में बहुत ही कम percentage होता है जिसमें 100% risk होता है for recurrence. ठीक है? So that is why it is out. Yes, that is 21-21 translocation. That is very rare translocation that occurs in Downs. So although Down syndrome is common out of these, but then Down syndrome में जो 100% risk है future sibling को होने का, that risk is very, very less, because जिस translocation से वो होता है उसकी percentage बहुत कम है. So if Downs is out, then which of the following options would you like to choose? Which one of these is an autosomal recessive disorder which has got inheritance pattern? So the answer over here is going to be option number B, that is cystic fibrosis. So if any disease that is autosomal recessive, what is going to happen? There is 25% chance of the next child to get affected, because it is 1 out of 4. Okay, so that is why this becomes the answer. अगर आपके पास cystic fibrosis के अलावा भी कोई option होता है which is autosomal recessive, you should choose that above Down syndrome, because in Downs the Robertsonian translocation, which is responsible for causing maximum risk of inheritance in the future sibling, is actually very low in incidence. So out of all these options, you should go best for cystic fibrosis. Hirschsprung and VST are sporadic disorders. So sporadic कहने का मतलब कि इसमें ऐसा कोई condition नहीं है कि first child has had this percentage of disorder, then the next baby would also have the same disease. ठीक है? So first question मैंने इसलिए ऐसा रखा है ताकि आगे से आप समझ जाओ that these questions are concept based question. That means that you have to think over it, you have to test your patience, understand the question, and then mark the right answer. So all your NEET PG is a mixture of question. You get both kind of question, that is one liners also, and you also get these concept based MCQs. All right. So next question. A pediatric surgeon is requesting an echocardiogram, that is 2D echo, on a hospitalized newborn who has got some congenital defect of the GIT tract. Which of the following defects has the highest incidence of associated cardiac defects? So which problem would occur out of GIT जिसके साथ आपका cardiac disorder is very very commonly associated? Very simple question, just that the language is turned upside down and it has been made lengthy. It's only asking you the disease out of GIT which has got association with cardiac problems. Please type in your answers, those who are listening. You don't have to be scared because of concept based MCQs. It is actually concept based. That means it is very, very simple to answer if you just use your common sense. So, any defect that you could see, which is a complete midline defect, which has got a lot of ventral abnormalities. So, if it is a midline defect, it will definitely involve your heart also. So, what could be the answer? Any disorder where you see that the midline is affected and it also affects the organs. So the answer over here is going to be option number A, that is omphalocele. So omphalocele is one congenital abnormality which has got GI involvement also because the ventral wall is affected and it also has got a lot of cardiac abnormalities. Okay. So cardiac defects are very commonly associated with condition that is known as omphalocele. All right. Is it clear to those who are listening? If you have any doubts, you can ask simultaneously also. We can keep discussing important things from the topic. So next question, question number 3. A 2-year-old infant has acquired SNHL, that is sensory neural hearing loss. His mother is asking what is the most likely cause which could be the reason and what is the least likely etiology of acquiring SNHL loss in a toddler. So there are many common causes which could be the causes of SNHL. So the question is demanding you out of all these common causes, which is not a likely etiology for SNHL. Out of these, which is not likely to be the cause of sensory neural hearing loss? So if you go by each option, it's very simple question to answer. Just a little bit of common sense is required. Which of these would not cause sensory neural hearing loss? Start typing in your answers. You can do a guesswork also. It's not an award winning session. It is neither a punishment. You should just exercise your brain so that you know that if these kind of questions, even 2 or 3 of these questions come from pediatrics, how would you exercise your brain to arrive at the right answer? So which of the following is not a cause of sensory neural hearing loss? So sensory neural hearing loss के causes बहुत सारे होते हैं. It is basically, yes. So sensory neural hearing loss can be caused because of many reasons. So hyperbilirubinemia is a well-known cause because it can also affect your CNS. It can cause kernicterus. It can cross the blood-brain barrier. The unconjugated bilirubin can cross the blood-brain barrier. It affects the CNS and therefore it can also lead to sensory neural hearing loss. Congenital infections definitely, like your cytomegalovirus, your toxoplasmosis, all of these organisms are very well known to cause hearing losses. Aminoglycoside therapy definitely is well known to be ototoxic. ठीक है. सो ये तीन तो बहुत ही कॉमन डिसऑर्डर्स है which can lead to your sensorineural hearing losses. So you're left with only option number D, that is neuroblastoma. Neuroblastoma has got nothing to do with your SNHL. So what is going to be the right answer? It is option number D, that is neuroblastoma. Okay, is it clear to those who are listening? So this is how you have to be very patient with the question. You have to understand and use your common sense to come at the right answer. All right, let's move to question number 4. Now, you're a practicing pediatrician where a cystic fibrosis is not a routine part of newborn screening. So, what could be the most important symptom in a newborn in whom you would suspect a cystic fibrosis onset? So, out of these, something which is present in the newborn age group that is clinically diagnosable or clinically helpful to diagnose cystic fibrosis. Clinical suspicion कब raise होता है? In which of these conditions that the child could have cystic fibrosis? What is one clinical feature that is present in the newborn age group? Please type in your options A, B, C, D. In the newborn age group, what could be present that could raise a suspicion that the child can have cystic fibrosis? Any guesses, anybody? Okay, so pneumonia basically does not present in the newborn age group. It presents later on, which is one of the most common manifestation of pulmonary complication that we have in cystic fibrosis. IUGR is not a very commonly seen finding with cystic fibrosis. Wheezing is definitely nothing to do with cystic fibrosis. So delayed passage of meconium or meconium ileus. This is a classical finding that we see in patients who are having cystic fibrosis. Okay, so classical finding in the newborn age group for patients of cystic fibrosis is having meconium ileus. So next question, question number 5. A term infant with microcephaly, jaundice and thrombocytopenia is thought to have congenital CMV infection. Which of the following is the most commonly reported sequelae of such infection? So if a child has got congenital CMV infection, if the child develops a congenital CMV infection, which of the following is the most commonly reported sequelae? So, what can occur as a complication following congenital CMV infection? Start typing in your answers, those who are listening, for question number 5, which is the most likely complication that can occur because of congenital CMV infection. So, as a later complication which can occur later at some age, which can be the complication? So later on, because of CMV infection, patients can definitely develop SNHL. So CMV is well known to lead to sensorineural hearing losses. So SNHL is a very well known complication that can occur in patients who have congenital CMV infection. So neurological complications are well known in patients of congenital CMV infection. So you should be very clear of the complications which can occur as a late onset complication. So question number 6. A newborn infant has got hemolytic jaundice. The mother did not receive any prenatal care and with this pregnancy or even in the previous pregnancy. There was a direct Coombs test which was positive. So direct Coombs test is positive and the mother's blood group is A negative and the baby's blood group is O positive. Her first baby did not have any feature of hemolytic jaundice, which is the most likely cause for hemolytic jaundice in this baby. It's a very simple question. The question itself is speaking out the answer. So there's a direct Coombs test that is positive. The mother was not enrolled for any of the prenatal checkup. The blood group of mother is A negative and the blood group of the baby is O positive. So what could be the most likely cause for hemolytic jaundice in this case? Please type in your answers, those who are listening. A very common cause during pregnancy that occurs which can lead to problems of hemolytic jaundice, that is rise in unconjugated bilirubin because of hemolysis, that is breaking down of the blood cells, red blood cells. So what could be the cause? The mother's blood group is A negative and the baby's blood group is O positive. So this condition is classically known as RH incompatibility. So RH incompatibility is a very common thing. This occurs because of incompatibility between the blood group of the mother and the baby. So because if the baby has got RH factor positive, it can go and sensitize the mother cell. So once it sensitizes the mother cell, what is going to happen once the next pregnancy is going to occur, then these sensitized cells, antibodies which are formed is going to come and attack the baby and it can lead to hemolytic jaundice in the newborn. So this is a very common scenario that occurs and RH incompatibility is a well-known complication that leads to hemolytic jaundice. Okay. So question number 7. An infant is born to a mother who has not received any prenatal care and you are requested to determine the infant's gestational age. So once you are doing it, which physical finding is most indicative that it is a full-term newborn? तो फुल टर्म न्यूबॉर्न के लिए कौन सा फाइंडिंग है विच इज वेरी वेरी क्लासिकल whether the veins and tributaries are seen all over the abdomen, there is long lanugo hair present on the back, you can palpate a breast tissue of less than 1 centimeter and there is pitting edema over the tibia. So out of these 4 findings, which finding would you see that is suggestive that you are dealing with a full term newborn baby? Please type in your answers, those who are listening. Option number A, B, C or D. So in this case, if you examine a premature baby or a term baby, there are certain findings. So veins and tributaries, if they are present in the abdomen, it is a classical sign of prematurity. If there is long lanugo hair which is present on the back, that is also seen in premature babies. If there is a palpable breast tissue of less than 1 centimeter, then this is only seen in full term babies. Full term, that means full term newborn babies, then only you can palpate a breast tissue. And pitting type of edema over a tibia is a pathological sign that has nothing to do with any feature of term or premature baby. Alright. So question number 8. So question number 8 suggests the blood bank has received an order for an intrauterine transfusion. So a fetus in which of the following would most likely require a transfusion before birth? So if you have to give a transfusion before birth to the fetus, which of the following could be a most common cause? If you have to transfuse the fetus with blood, what could be the cause for such a transfusion? It's a very simple question. If you just use your common sense a little bit, I think you'll be able to understand the meaning of the question. So fetal transfusion has very less indications and it is a very complicated thing to do. But one classical indication that we have for it is erythroblastosis fetalis. So this is one classical indication where you have to go and transfuse the fetus because you have to prevent the fetus from dying due to anemia and due to breakdown of the cells. Okay, so sickle cell anemia does not require any transfusion as such. Spherocytosis does not require, and fetal distress and bradycardia is also no indication to transfuse the cells, to transfuse the fetus with blood cells. So next question, question number 9. During a routine prenatal visit of a mother who states that she has been knowing about what is kernicterus. So if the mother is educated, they can come and ask you various questions. So you should be aware of how to educate and tell them about the findings. So in this case, she is very concerned that her infant could also develop kernicterus if she gives her breast milk. For the infant, since she has also read that breastfed babies can have high levels of bilirubin, which is absolutely true. So this is one complication that occurs in an exclusively breastfed baby. So which of the following is most predictive for the development of kernicterus? So what happens which is definitely diagnostic that the child has developed kernicterus? Out of these four options, which is the option that clearly defines that it is kernicterus, and what occurs in kernicterus? Is it option A, B, C, or D? Hyperbilirubinemia within the first 24 hours of life, peak levels of conjugated bilirubin, peak levels of unconjugated bilirubin, and duration of hyperbilirubinemia. So, what could be the answer to question number 9? What do you understand by kernicterus? So kernicterus basically occurs because of the breakdown of the RBCs and because of hemolysis as well. So it is increase in the unconjugated bilirubin levels. So once the unconjugated bilirubin levels would increase, it is going to lead to kernicterus. So unconjugated bilirubin rise होने के वजह से there can be many other complications. So breastfed babies में जो jaundice होता है, that is basically unconjugated bilirubin levels due to breakdown of the cells and because of various other causes like blood group incompatibility or RH incompatibility. So it is unconjugated bilirubin levels that is going to rise. All right. Question number 10. Prevention of bilirubin encephalopathy or kernicterus is one of the goals for the appropriate diagnosis and treatment of hyperbilirubinemia. Which of the following mechanism has got a role in preventing these adverse outcomes? So, which is the mechanism which acts in our body to prevent any adverse outcomes of having a very high bilirubin levels in a newborn? So, what would happen to the increased unconjugated bilirubin so that there is no complication in the newborn? What is the answer to question number 10? Start typing in your answers, those who are listening. These questions are lengthy. These questions might help you feel a little palpitated, but it is very simple to understand. If you know the concept, it is definitely going to be very, very easy. Yes, option number B is the right answer. So unconjugated bilirubin gets tightly bound to albumin. So because of this reason, what is going to happen? It is going to be life-saving, or this mechanism has the role in preventing adverse outcomes in the newborn. Okay. So question number 10, the answer is option number B. So question number 11, you are assessing 1 week old term baby. Okay. So the mother has been exclusively breastfeeding. The baby is absolutely exclusively breastfed and you're not sure how to interpret the change in infant's weight compared to the birth weight. So what is the most expected weight change that you will find baby? That is what the question is trying to ask you. One classical thing happens at the end of first week of an exclusively breastfed healthy infant also. So what is that one thing that happens? Just read out the options A, B, C, and D and tell me the right answer. This is absolutely normal for all the newborns. And yesterday also we have discussed it in the MCQ marathon. So what could happen to a normal newborn at the end of 1 week? Is there gain in weight? Is there loss in weight? Which is the normal phenomena that happens? What is the answer to question number 11? Come on, just think about it. Yesterday only we have discussed. Those who have listened to yesterday's session also would know the right answer. So at the end of 7 days, there's classical weight loss. How much weight loss is there? 5 to 10% of the birth weight. ठीक है, इतना loss हो जाता है, and then by the end of 10 to 14 days, it is gained back. So this is two important thing which is absolutely normal in a newborn. So 5 to 10% loss of the birth weight occurs in a normal term baby, and then it is regained back by the end of 10 to 14 days. Okay. All right, so next question, question number 12. Which of the following is the most closely associated with the development of neonatal respiratory distress syndrome? So one thing which has got a very high risk factor for development of RDS, which factor is related to the development of respiratory distress syndrome? Is it gestational age or prematurity, one and the same thing? Or is it birth weight? Or is it having a cesarean section? Or is it maternal diabetes? Which of the following could be the cause for developing neonatal respiratory distress syndrome? All of those who are listening, please type in your answers. Don't just try to listen to the questions. It is just to exercise your brain so that you're able to answer it normally in your main exam also. You're able to think over these questions. So what is the answer to question number 12? Any more responses? So respiratory distress syndrome, necrotizing enterocolitis, intraventricular hemorrhage, all of these are complications which are well known for prematurity. So the answer over here is going to be option number A, that is gestational age. जितना कम gestational age होगा उतना ही ज़्यादा risk होता है to develop these complications in a premature child. Okay. So don't get confused with other options. It is very, very simple to understand. All these neonatal complications are common in premature babies, and gestational age is a very important deciding factor for what is going to be the outcome of complications. Okay. Question number 13. So there's again 1 week old term newborn who has got oral candidiasis, जिसे हम thrush कहते हैं. Which of the following is the correct statement regarding thrush in a normal newborn? It would respond well to topical therapy with nystatin. It requires systemic therapy with amphobi. It requires both topical and systemic therapy. It requires investigation to rule out 20q11 deletion syndrome. So what would you mark for this? Answer to question number 13. If a normal healthy newborn who was healthy is having a term newborn is having oral candidiasis or thrush, what is the correct statement regarding the treatment of thrush in a normal newborn? Any more responses? Option A, B, C, D. All of those who are listening, please type in your answers. So oral thrush or candidiasis is only treated topically. This is a topical infection. You don't need to give any IV treatment, चाहे वो newborn हो या pediatric age group हो या adult हो, ठीक है? So the answer is responds well to topical therapy with nystatin. Nystatin is an antifungal, and if you give this, the treatment response is going to be adequate enough. You don't need to give IV antibiotics for this condition. All right? Is it clear to all of you, those who are listening? If you have any doubts, you can share as well. Question number 14. There's a low risk newborn infant who has got pathological unconjugated hyperbilirubinemia. Why the infant was not jaundiced immediately after birth, and which of the following best describes the major route for excreting out bilirubin in the fetus in utero? So when the baby is inside as the fetus, what mechanisms plays a very important role for excreting out bilirubin in the fetus? So in a fetus, which mechanism plays a very important role for decreasing the bilirubin? Is it through the kidney? It is because of transplacental passage? Is it because of your degradation of biliverdin? Is it because of reincorporation into hemoglobin, or because of hepatic secretion and storage in the intestinal lumen? So what could be the answer? So there's a confusion between two options. That is why I've put five options. So it could be answer option B also and E also. That is transplacental passage is one reason that prevents sudden onset of hyperbilirubinemia in a fetus. And if these babies have had some problem, immediately after birth, they don't present with jaundice. They would present after some time, that would go into the category of pathological jaundice. Okay, so not immediately at birth they will not present. And another option that could be right is hepatic secretion and storage, which occurs in the intestinal lumen, that could help to clear it out through the enterohepatic circulation. So both options are right, but because they are classically demanding you in fetus in utero presentation, मतलब in fetus में कौन सा mechanism सबसे important है, so according to the question you should go for option number B, that is transplacental passage. So transplacental passage is very important. Bilirubin, especially the unconjugated form of bilirubin, can easily cross the placenta. So if it is able to cross the placenta, so it is going to lead to, so this is going to lead to will not lead to jaundice immediately at birth. So this is one mechanism that is going to prevent the sudden onset of jaundice at birth. So you should go for option number B, and option number E is also right. But if they're classically demanding only in fetus in utero, then option number B is going to be the right option. Question number 15. So an obstetrician is performing the intrauterine transfusion and is counseling the mother regarding the complication of this procedure. Which is the most common complication that can occur after doing an intrauterine transfusion? If you do an intrauterine transfusion, what could be the most common complication that can occur after that? It is asking the most common complication, not rare complication. तो मोस्ट कॉमन कहने का मतलब है जो काफी लोगों में हो सकता है. If there's a mismatch, do you think everybody does not match the number before transfusion? So mismatch is not very common. So if accidentally if somebody has not matched the blood bag, it can lead to that complication. But most common complication क्या हो सकता है if you give a transfusion? So it is option number C, that is premature onset of labor. So अगर आपने बाहर से intrauterine transfusion कर दिया, then there can be premature onset of labor in the pregnant female. So this is the most common complication that occurs because of intrauterine transfusion. All right. Question number 16. A 3-day-old infant is requiring phototherapy for hyperbilirubinemia. Which of the following risk factor best predicts the occurrence of ABO isoimmune hemolytic disease in the newborn? So those children who require phototherapy for hyperbilirubinemia, which factor could help you to decide the occurrence of ABO, isoimmune hemolytic disease in a newborn? So most commonly किस conditions में ABO incompatibility होती है? Very simple question. Only if you understood the meaning of the question, you can easily answer it. What is the answer to question number 16? ABO incompatibility का मतलब क्या होता है? Question में ही answer है. You don't even have to think too much. Obviously, if the blood group is not compatible. So if the mother blood group is O and the infant is type A, then it can lead to ABO incompatibility. And mostly this is the combination that occurs in ABO incompatibility. That means that the mother is on O and the infant or the baby has got either A or B. So what happens, जो O में अगर जो mother O होती है, then the antibody that is formed against this reaction, that is IgG type. So IgG type can easily cross the placenta. So if it is crossing the placenta, it can easily go and react as well. So if the mother is type O and if the infants or the baby that she is having is type A or B, it can very easily lead to ABO, isoimmune hemolytic disease in the newborn. So this can again lead to hemolysis, leading to hyperbilirubinemia, and these children require phototherapy for their management. Okay, is it clear to all of those who are listening? I think this quiz is becoming a little tough for all of you, but you do get questions which are concept based. Like yesterday, we did simple one liners. That is the beauty of NEET PG exam, but also you get concept based questions. So you should be able to handle both type of questions in the exam. Okay, question number 70. A 29-week gestation infant is being resuscitated in the delivery room. The surfactant is given through the endotracheal tube. Which of the following is the most physiologically active component in the surfactant? So surfactant में जो components होते हैं उसमें से सबसे important component कौन सा है? Very simple question. तो हमारे सर्फेक्टेंट के कंपोनेंट में से सबसे पोटेंट और सबसे ज्यादा एक्शन कराने वाला कंपोनेंट कौन सा है, विच इज गोइंग टू इमीडिएटली लीड टू लंग मैच्योरिटी? So our surfactant has got many components in it. It has got lipids, phospholipids, surfactant, protein. But out of all of these, the phospholipid component is the component which is most potent and has got the best action in causing lung maturity. Okay. So phospholipid is the most important component or the most potent part that helps in the lung maturity. All right. Okay, so question number 18. A mother presents in active labor. She did not receive any prenatal care and is not sure about her LMP. So LMP से हमें क्या पता चलता है? Gestational age and the expected date of delivery. Using ultrasound, the estimated gestational age was around 30 weeks. Which of the following could best describe the average birth weight of a 30-week gestational infant? So this is a guesswork question. Nobody can remember the whole chart. But if you know the normal weight of a newborn, if you know what could be the expected weight in a 30 weeks old gestational age wise old baby, so you have to just guess the most appropriate weight over here, which would be the answer. So अगर normal weight देखो और 30 weeks gestation देखो, then you can make a wise guess over here. What could be the answer to question number 18? All of those who are listening, please type in your answers. Whatever you think is the answer, you should type in that in the chat box so that you can also exercise your brains. Any guesses, anybody? So here the answer is going to be 1500 grams. That is 1.5 kg. So normal birth weight that we take is 2.5 kg. So that is around 37 completed weeks. So from 30 to 37 completed weeks, we have got approximately 7 to 8 weeks for the growth. So if you guess this question wisely, even if you don't know the exact charts, then the answer is going to be option number C, that is 1500 grams. Okay. And otherwise, you can just remember the basic cutoffs at basic gestational age. But 30 weeks, definitely you can calculate backwards also from the normal birth weight that is expected. So question number 19. A newborn is hospitalized for 2 weeks and is treated with phototherapy for 12 days. and also required a red cell transfusion during the hospitalization. Which of the following is the most common serious clinical manifestations of this ABO disease? So, which is the most common serious manifestation that can occur because of this ABO disease in the newborn? That is, your ABO incompatibility can lead to which of these following serious manifestations? Such a prolonged jaundice requiring phototherapy for 12 days, and there has been many transfusions also during hospitalization. Transfusions during hospitalization. So, what could be the most common and serious clinical manifestation of this ABO disease that has occurred in the newborn? If you give many transfusions to the baby, what can occur? Very simple question. ज़्यादा ब्लड ट्रांसफ्यूजन देने से क्या हो सकता है? Yes, the right answer over here is congestive cardiac failure. So if you give multiple transfusions, the baby will have overload or will go into high cardiac output failure. Okay. So this is going to happen if the baby is going to receive a lot of transfusion. And why is the baby getting transfusions? Because of ABO incompatibility. That is why they have specifically mentioned that the baby required red cell transfusions during the hospitalization phase. Okay. Very simple question. A newborn is admitted to you with history of being born to the diabetic mother. So the baby is on exclusively breastfeeding and becomes lethargic at times also. Which of the following is the most likely cause and the treatment? So infant of diabetic mother pe many questions have come. You should be very sure about each and every complication and treatment of each and every complication. So if IDM is admitted with you and the baby becomes lethargic in between, what is the most likely cause and how would you treat it? What is the cause of IDM becoming lethargic? What happens in infant of diabetic mother that they become lethargic? And if so, what would you do for the treatment? Start typing in your answers. Those who are listening, it's a very simple question. Infant of diabetic mother में क्या complication होता है? And if that complication is there, is it permanent? Is it transient? How would you treat it? It's such a common sense question. Even if you think and read all the options, you would be able to guess the answer. Is it going to be hyperglycemia in IDM? Absolutely no. Infant of diabetic mother में क्या हो सकता है? The complication is hypoglycemia because of overaction of insulin. Insulin के वजह से ही सारे complication होते हैं, चाहे वो hypoglycemia हो या hypertrophic cardiomyopathy हो, ठीक है, या macrosomia हो, all of this occurs because of action of insulin, ठीक है. So hypoglycemia is there, but there are two options. IV dextrose दोगे या breastfeed कराओगे? So IV dextrose to be only give if the baby becomes very much symptomatic, like going into seizures or having any abnormal neurological outcome. But insulin effect is transient over here. It's not an underlying defect which you need to treat, and especially through the IV dose. So what you're going to do, you're only going to continue giving exclusive breastfeeding so that the baby does not turn hypoglycemic, and every 2 hourly you can feed the baby so that the blood glucose level is maintained and the baby does not go into hypoglycemia. So the answer is going to be option number C. Is it clear? Okay, question number 21. An echocardiogram was done for a small ventricular septal defect and a patent foramen ovale. Regarding the role of foramen ovale in fetal life, which of the following statement is true? So which statement is true for foramen ovale? Very simple question. होता क्या है foramen ovale और कौन सा सही statement है regarding foramen ovale? So just read all the options. First option says that the blood flows through the foramen ovale from the right ventricle to the left ventricle. Second option says that the blood flows from foramen ovale from the left ventricle to the right ventricle. Third option says that blood flows through the foramen ovale from the left atria to the right atria. And last option says that the blood flows from foramen ovale to the right atria, from the right atria to the left atria. So it's a very simple question. What would be the answer to question number 21? From where does the blood flow in a foramen ovale? Where is foramen ovale situated? Please type in your answers, those who are listening to the class. The foramen ovale is situated over here. इसी की closure नहीं होती है, then what happens? There's a shunt known as atrial septal defects. Okay, so इसमें basically blood flows from right atria to the left atria. So simple answer option number D, that is blood flows from the foramen ovale from the right atria to the left atria. Okay. Alright, question number 22. Which of the following is true of the surfactant production as it relates to respiratory distress syndrome in premature infants? So surfactant के बारे में सही statement क्या है? Very simple question. Yesterday also we had this question, but now they have framed it in a lengthier part to scare you, but the concept remains the same. So जिनके concepts clear होते हैं उनके लिए MCQ बनाना भी आसान हो जाता है, because everything is based on what you have learned so far. Okay. The foramen ovale is from right atria to left atria, and if it remains open, it is going to lead to problems of atrial septal defect. So question number 22, the right answer is option number B, that is surfactant is synthesized and stored in type 2 alveolar cells. So type 2 pneumocytes होते हैं which are responsible for your surfactant production and storage. Okay. All right. These simple points अगर किसी और तरीके से भी आपके एग्जाम में आ जाते हैं, you're able to answer it because of the quiz, I'll be more than happy that you are able to learn it from the quiz only. And if you have studied it, then it's all the more better for you that you would be knowing it throughout the concept कि इसका आंसर क्या है. Okay. So a mother presents for prenatal care with a complicated medical history. Which of the following condition most commonly predisposes the fetus to congenital heart disease? So out of all the medical complications that we read and study about, which of the following complications is seen? Which of the following medical complication is seen if the child develops congenital heart diseases? Is it hypertension? Is it diabetes? Is it atherosclerotic coronary vascular disease? Is it rheumatoid arthritis? What is the right answer? So it's very simple. इतने बार पढ़ चुके हो. Diabetes mellitus में you get so many complications. क्या क्या होते हैं? VST, TGA, hypertrophic cardiomyopathy. All of these are seen in patients who are diabetic, and their fetuses can develop these kind of cardiac complications. All right. Question number 23 clear? Question number 24. A 25-week gestation infant is born to a 25-year-old primigravida who has had got preeclampsia. Which of the following is a true statement describing the neonatal mortality rate for this infant? So neonatal mortality rate में which of the following is the true statement? So neonatal mortality rate है that decreases with increased gestation. Is it true? Neonatal mortality is not related to birth weight. Is that true? It is not related to congenital anomaly. Is that true? And neonatal mortality is higher in developed country. Is that true? Which of the following does it sound that it is a true statement? A, B, C or D? Please type in your answers, those who are listening. So answer to question number 24. Yes, the right answer is option number A. So it is inversely related. जितनी prematurity होगी उतना ज़्यादा death rate can increase. ठीक है। जितनी प्रीमेच्योरिटी होगी मतलब जेस्टेशन एज से इनवर्सली रिलेटेड होता है। जितना ज्यादा प्रीमेच्योर होगा उतना ज्यादा एक्सपायरी हो सकती है, जितना कम प्रीमेच्योर है उतनी कम एक्सपायरीज होगी। एंड न्यूनेटल मोर्टेलिटी इज डेफिनेटली रिलेटेड टू बर्थ वेट. If somebody has got extremely low birth weight, then they are more prone to have mortality. It is related to congenital anomalies. All the complex congenital anomalies can definitely have a higher expiry rate. It is higher in developing countries, not developed countries. Okay, so it's very simple question. Option number A is the right answer. All right. So question number 25. A newborn is admitted to you in NICU with undue complaints of having respiratory distress. He was ventilated also due to excessive CO2 retention. Okay. On examination, you find that the baby has got wild pulse pressure. Which of the following could be the most likely cause for such a situation? So very important pointers: respiratory distress, CO2 retention, ventilation, wide pulse pressure, all of that fits into one classical condition. What could be the answer? Question number 25. So this classical clinical condition that is mentioned over here is seen in a condition that is PDA. ठीक है, patent ductus arteriosus. ठीक है, तो पेटेंट डक्टस आर्टरियोसिस में बेसिकली और हार्ट हैज गॉट 4 चेम्बर्स, और यहाँ से जहाँ पल्मोनरी और अयोटा का पार्ट होता है वहां पे देयर इज अ पेटेंट डक्टस दैट इज प्रेजेंट व्हिच इज गोइंग टू कन्वर्ट द शिफ्ट शंट इज गोइंग टू बी प्रेजेंट फॉर राइट एंड लेफ्ट. So from here whatever blood is coming can go to the right side of the heart. So patients are acyanotic, एंड बिकॉज ऑफ दिस शंटिंग देयर इज ओवरलोड ऑन दी लंग्स, क्योंकि ये सारा ब्लड लेफ्ट से आपके राइट में जा रहा है, राइट से अल्टीमेटली घूम के वापस से लेफ्ट साइड ऑफ द हार्ट में आएगा. So the lungs over here gets congested. So there is undue respiratory distress in a newborn because the lungs is small and it has to work so much to pump out so much of blood and to purify so much of blood. So there is respiratory distress as well. And because the lungs are so small and so much gush of blood is coming to get purified because of the overload from the shunt of left to right type, so they are going to have undue CO2 retention on ABG. जब भी आप ABG करते हो PDA के patient का, you will find that O2 is decreasing and CO2 is rising. So in that case, because of misinterpretation, because of presence of respiratory distress, and because of undue CO2 retention, what is our reflex? That we intubate the baby. Okay, so they get mechanically ventilated also because of having severe RD and CO2 retention on ABG. But this is classically seen in patients of PDA, and because there's a continuous flow that occurs from left to right, and this all the blood goes back to the left atria, to the left ventricle, then what is going to happen? In this condition there is going to be a wide pulse pressure, क्योंकि दोनों के बीच में कितना डिफरेंस है, लेफ्ट साइड इज गेटिंग सो ओवरलोडेड एंड राइट साइड डज नॉट हैव टू मच ऑफ ब्लड टू पंप आउट, so it is going to lead to wide pulse pressure. Okay, is it clear to all of you? So PDA is the classical answer over here. So those who are listening to the class, do you want to continue with another 25 MCQs today, or do you want to shift it for the next session? Because these are all concept based MCQs, you need to stay fresh, think over the questions and then mark your answers. So do you want to continue ahead with another set of 25 questions, or do you want to revise it in another session, obviously before your exams? Please type in your response. Do you want to shift it to a next session? Because we have already discussed 25 MCQs. So nobody should feel scared and nobody should get depressed or anything. It's very important to stay confident with whatever you have studied till now. All you need to do is to revise everything that you have read. So these MCQs are very good ways to revise whatever topics that you have read, because it is going to help you solve everything, help you understand all the questions. It gives you a very fast revision also. And if you have read your topics properly, you feel confident on solving MCQ. So it gives you a good feeling also from inside कि चलो मुझे ये topic अच्छे से आता है. So do you want to continue or do you want to shift it to the next session? I can take it another set of 25 MCQs in another class. So those who are solving the MCQs with me, please respond. Okay, so we'll take it for the next time. I can understand the 25 MCQs, I think, is more than enough to revise neonatology from. So I'll plan another session with another set of 25 MCQs. So I request all of you to please attend the class. With these 100 MCQs that we are doing from neonatology, I think most of the topics is going to get covered, and you will. I hope that you get questions like this in the exam so that you can answer it easily and you feel confident that yes, your neonatology was done nicely. Okay, so all the best to all of you. Thank you so much for listening. And I wish that all of you perform wonders in the exam and all of you do really, really well. Neonatology is one of the most important part, definitely, but most of us tend to ignore it because we feel that maybe it's not good enough time to read neonatology, or maybe sometimes that we feel neonatology is not important, but definitely you get questions from this. So please don't leave it. At least revise the notes that you have made, or if not, then you can at least revise whatever MCQs that I have done, because it covers by and large the normal newborn also, and it also covers your diseases of the newborn as well. Okay, so I'll most likely take the session by tomorrow or day after tomorrow, where we'll finish another set of 25 MCQs. So that will cover up all the 100 MCQs from neonatology, which has been picked up as a mixed bag from various systems and also from the normal newborn. So please stay calm and do not panic. I wish all of you stay calm and you don't panic for your exam. So I'll definitely upload the next session, most likely by tomorrow or day after tomorrow, where we'll discuss another 25 MCQs on newborn. So as of now, we have Bugs Bounty, which is one feature that Unacademy gives you. You can also report any inappropriate content in the video. And for those who have not started to follow the Telegram channel, please download Telegram and download and start following us on Let's Crack NEET PG. If you do that, you get a lot of updates about all the important classes that we are taking and all the important sessions that we have. और जिन लोगों ने सब्सक्राइब नहीं किया है, please come and subscribe for the plus class. I'm also starting my 2022 beginners approach batch from tomorrow. So those who are targeting the next year's NEET PG exam, you can come and join this lecture tomorrow at 4 p.m. So here I'll be discussing what should be your approach towards reading pediatrics and neonatology and social pediatrics and pediatric psychiatry and everything from this subject. What should be referred to, how much you should read, how much time you should take, what are the important topics that you should cover first, which MCQs you should do, and how should be your approach to finish the subject in what stipulated time. So what could be the best thing that I could do is to have an orientation class in one day and then to help you start revising very basic topics from the next class. So those who are targeting the 2022 batch for your PG exam, you can start attending classes from tomorrow. So I'll be starting the orientation from tomorrow, and slowly we'll begin with small little topics from pediatrics and gradually build up our thought process to complete pediatrics in good amount of time. Also, those who want to attend the classes in a systematic manner, and like we were doing cardiology and all the important units, you can take the subscription of Plus. If you take the Plus subscription, you can use my code, that is Kavita S10. If you put down this code, you get instant discount of 10% off on your subscription package, and then you have the benefits to come and attend the classes on the app, which is a paid class. So over here you get complete lesson structure. जैसे मैंने अभी cardiology start किया है, so you will get all the lectures on cardiology, which covers all the important topics that you need to know, right from your congenital heart disease, development of heart, all the acquired heart diseases and everything. So after cardiology, I'll be starting this month respiratory pediatrics. So respiratory is a very important unit. You get many questions from here. So you should know all the congenital anomalies. You should know all the chronic lung conditions. You should be aware of all the treatment and protocols that we have for treating of pneumonias, what are the different types of pneumonias, then there are n number of questions from respiratory. So please come and join for the plus hour so that I can teach you the complete unit in a well defined manner, and you are able to understand the whole chapter and revise it very nicely before your exam. So thank you all of you for being a part of this quiz. It was very interesting to teach you guys. So I hope all of you have revised neonatology, and those who have not, please take out few hours before your exam, because it is a cream topic from pediatrics, and even few questions if you get and you answer